Hello, hello, and welcome back to AMCI. We have prepared another wonderful presentation for you today, but I just want to say, how are you? Are you all excited? Hopefully, you are because we truly are excited. This is probably one of the most requested events that we have. We always have every year. So thank you so much for joining us. Again, as I've said, we prepared a wonderful presentation for you, another one of our March Madness major events. But before that, allow me to go ahead and take care of some technical things out of the way. Just make sure that if you are viewing on a work phone or a work computer, you may want to go ahead and check your firewall settings right now. Webinar tells us about this, that sometimes the firewall settings of your work phone or computer may interfere your ability to view this webinar. So if you know about that one, may involve you, then make sure that you check out before, we continue on because that might interfere with the video thing later on. But if you're viewing us on a computer, also make sure that you go ahead and check your audio panel rather, to make sure that the settings are correct. It should be set to computer audio. And if you are viewing us on a phone, make sure that you are doing so by downloading the GoToWebinar app. So this comes from Webinar, and hopefully everything will have a very good webinar experience today. All right, and then just an important information about your CEUs. So for today's event, you're actually going to have 3 free CEUs attached to this webinar. But you must take an assessment upon completion of this event. You will receive this in a webinar email responder 1 to 24 hours after the presentation. And you must complete your CEU test assessment within 48 hours. Now, the thing is, you are not allowed to share this link with anyone. This is a violation to AMCI APC copyright clause. And when you are taking the assessment test, make sure you provide the full name and the correct information in your assessment for APC and AHIMA verification. All right. How do I sound to you guys before I move on? Actually, I want to make sure. I should have asked that earlier. All right. So far, hopefully you can hear me okay. All right. Thank you for letting me know. Thanks. Okay. Now we can move on. So I just want to remind you that we are giving away a lot of free CUs and paid events as well for AMCI 2021 March Madness. We are full on. We are, I think, coming into the third week, and next week actually is going to be the 12 CU event. So please don't miss out on it. It's 12 CUs, 3-day event all about PCS coding. So if you haven't registered on that one, I don't think you want to miss that one, right? 12 CUs. I have to say that again. And it's free. So make sure that you register. Just go to our website and find us in the calendar and then register from there. Now, if you are wanting access to our AMCI Playback, it's available to you already. I think the price may have gone up because I think the promo is up to March 15. But if you want to avail it, just go ahead and ask our customer service. They're always happy and willing to accommodate you. Like I said, we now have all access to our AMCI playback and paid events for only $100. If you missed a few that you really wanted to see, this is going to be your chance to be able to have access to those playbacks for only $100 plus the CEUs attached to it. So that's really a great deal, right? And also, anytime you need a CEU, please come in. Just come to our website. We always have CEU available for you in a way of a CEU course. Our CEUs are actually approved. APC and AHIMA approved. So you can have it on demand, and it's going to be all available to you starting April 1st of 2021. And another thing, a lot of you have been asking about the charts that we use for our principal and first listed if you attended that webinar, or are you asking about how do you or where do you get those FTRs, your CHAN? A lot of those are actually part or in our MCG manual. This used to be called our TTT manual, but now we call it the MCG manual because it's all in one book. It's really good for those who are studying medical coding to pass the exam. We use this manual a lot to help our students, go through the course and pass the exam. But a lot of our alumni actually usually buy them every year. They use it for work as code and guideline reference. So if you want to avail our MCG manual, all you need to do is go to our website, www.amcicoding.com/MCG. This one is really a good one. We call it the MCG Coding Buddy. And another thing, we are also going to be using Final Code. We love Final Code. So if you're looking for an online encoder, we recommend Final Code. They have really good ones for ICD-10 CM codes, CPT codes, and HCPCS codes, even PCS codes. And just go in there and check out. They have great resources, especially for a lot of you who are working in the medical coding fields. And now it's time for us to go ahead and meet the A team. My name is Mr. Shell, and I actually am joined by, of course, our wonderful Miss Tracy today. And I'm going to actually give the floor to her. She will be introducing the rest of our team and our wonderful presenter for today. So, hello, Miss Tracy. How are you?
Hello, hello. Hey, Miss Rochelle. Hello, everyone. Welcome. I'm so glad you all are attending today. You guys are going to enjoy this presentation, but I do want you to meet the A team. So, our A team includes Miss Becca. I'm sure a lot of you have heard from her. She works her magic behind the scenes in our customer service department. We call her the customer service angel. I'm Mrs. Tracy, one of the instructors here at AMCI. Miss Rochelle, you just heard from her. She's another one of our instructors. Miss Michon, another one of our lovely instructors, as well as Miss Tamika, and Miss Bennett is works, kind of behind the scenes, and she's one of the proctors for our MMM exam. Miss Crystal's one of our co-instructors, and then Miss Mills, she works behind the scenes in customer service as well. And then, of course, the woman that makes all the magic happen, and she is, also an instructor here at AMCI, as well as the director of curriculum, and that is the wonderful Mrs. J. And if you have been following us throughout March Madness, you've heard from me, Miss Rochelle, and Mrs. J mostly. So again, we all want to welcome you, and we do have some amazing assistant instructors: Miss Andrea, Miss Takima, Miss Tiffany, Miss Carla, Miss Denise, Miss Lakshmi, Miss Sarmi, Miss Patricia, Miss Kamisha, Miss Brenda, Miss Shalini, Miss Stacy, Miss Mew, Miss Han, Miss Melody, and Miss Tiffany. And I know a lot of them are joining us over there on the other side, so we want to say hello to you all. Now, it is my absolute pleasure and such an honor for me to introduce our lady for the next 2 hours. This was going to be our presenter for the day, the absolutely amazing Miss Shirley. She is out of Pennsylvania. She is a CPC and a CRC. She is a risk adjustment coder at the moment, and I think risk adjustment is her passion. So without further ado, please help me in welcoming Miss Shirley. And I hope you all enjoy the presentation.
Hello and welcome to HCC Coding. My name is Miss Shirley and we're going to get right into it. Our goals of our presentation today, first of all, we want to achieve an understanding of risk adjustment basic concepts. We want to achieve an understanding of HCC coding concepts, and we want to successfully complete practical HCC coding exercises. And we're going to start out with two cars. What an unusual way to start talking about medical coding, but we're dealing with insurance here. And so to work our way into a discussion of what risk adjustment is, we're going to start with cars because we all understand a lot about car insurance. So we see two cars here. They look identical, don't they? They're brand spanking new. Two different owners have purchased these cars. They have the exact same features. These people, they go to the same agent. They get equivalent policies. They live on the same block. They park their car in a garage. All the other things that insurance agents think about when their policy is being set, everything is equivalent except for one thing. And that is the first driver is a new driver. You can see he's proudly displaying that brand new driving license. There's no experience yet. And the second driver is a highly experienced driver. He has a great driving record. So the bottom line, the insurance company expects it to be more costly to cover this inexperienced driver than it is to cover the experienced driver. They are assuming more risk, and so therefore the policy is going to be more expensive. And keep that in mind as we transition now to looking at two patients. So we're in the healthcare world now. And we see our first patient here. He looks pretty darn healthy, doesn't he? You can see that he's very fit. He works out, he lifts those weights, he runs on the treadmill, he has got a happy heart, has a healthy weight. So he's, relatively speaking, a healthy guy. And we look over here and we see the opposite kind of person. We see somebody who looks pretty stressed out, carries some extra weight. It's a smoker. Look at those lungs. Oh, not happy campers. And look at that heart. Also not happy. And so this is a less than healthy person in terms of lifestyle, and probably going to have conditions that go with those. And so our healthy person, there's less risk, therefore less cost involved in insuring that person. The less healthy person, greater risk, and it's going to cost more to take care of that person. All right. So HCC coders, we tell a patient's story. We use ICD-10 CM codes to tell that story, the patient's health, over a given period of time. Now, if you're working in a doctor's office as a coder, you're coding an individual encounter. You know, when you work in risk adjustment, you cover a range of dates. And those dates can vary in a given project. It could be a few months or it could be a couple years long. HCC coders, we select those codes that risk adjust. And these are conditions that are more serious and costly to treat. The conditions may be chronic or acute. There is misinformation that I hear. There are folks that think that risk adjustment coders, we only select chronic codes, but that's really not true. It's not whether the condition is chronic or acute that's the driving factor. It's how relatively serious and costly it is. So we go to a mapping tool. CMS provides us with a mapping tool, and we find the codes that risk adjust in that mapping tool. And we'll talk a little bit more about mapping tools as we go through this training. So what is risk adjustment? Risk adjustment is a methodology used to determine funding allocations to insurance plans based on the severity of disease of the enrollees, as well as some other factors like demographics. And there are a couple different things that fall under the risk adjustment umbrella. One is HCCs, and the other is RxHCCs. I say, oh, okay, what are they? And HCC is a condition-based category that contains related medical conditions that risk adjust. And you'll see an example of that in a couple minutes. RxHCCs are medication-based categories that contain related medical conditions that risk adjust. You see here, HCC pertains to Part C, that's our Medicare Advantage plans. RxHCC pertains to Part D, which is Medicare drug coverage plans. So we're going to take these words. The HCC represents hierarchical condition category. So we need to understand these words in order to understand what HCC or risk adjustment coding is all about. And we're going to start at the end. We're going to start with category. And when I think of category, I think of a grouping of related items. When I think of condition in healthcare, I think of a diagnosis. Hierarchical, we have things going higher. I think of ranking. And so it is a ranking of diagnoses that have been grouped together. Now, within that hierarchy, codes get assigned risk adjustment factors, or actually the category gets assigned the risk adjustment factors, and they can be trumped. And that's just a little hint of something that's coming up. Hierarchical condition category, here's a definition of it. It is a group of related diagnoses with associated risk adjustment factors that correlate with the relative severity and projected costs of providing medical care for members' diagnoses. And those of us that work in risk adjustment, we call the codes for these diagnoses HCC. So if I'm coding COPD, J449, I might say it's an HCC. If I'm coding acute bronchitis, I'm going to say that, and I may say that's not an HCC. Okay, just a little snippet there. So here's an example of a category. This happens to be category 85. Here's the number all down here. These are the codes. Okay, notice the periods are not there. Okay, so this is I50.1. I50.20. Here's the description. If we look at these descriptions, look, it's heart failure all the way down. These are all codes about heart failure. And they are, so it's a group of related conditions that have been put into one category, and they've been assigned a factor, a risk factor. Now, this is a risk score calculator tool, and it's a sample, okay? And it's in Find a Code, which is an encoder that I really like to use. And we're going to look at it live in a couple minutes. But you see, I've put several diagnoses here. Here's the description. Here's the HCCs that they fall under. So diabetes without complication is 19, emphysema 111, and then hypertension, it says none. The reason it says none is that this is set up to just calculate HCCs, and hypertension falls into an RX HCC only. It's not considered an HCC code, but it does map to RX HCC. Then these are some demographic things, and obviously that they can be adjusted. I hit calculate, and this information comes up. So here's that demographic, they call it a base factor, okay? And there's a score, and this is the risk factor score. And then I have this category 9 and category 111, and they have scores, and it all gets added up. This is an additive process. Now we're going to go out and look at the real thing. Okay, now this looks a little different. They have updated the formatting of this whole website, the whole encoder, since I did that clip, but it does the same thing. So, and that's what's important. So I'm gonna put a couple codes in here, 1122, type 2 diabetes with chronic CKD, and we know with that we're going to code the stage. Alrighty, so I'm going to keep our patient female, going to make her a little older, and I'm going to leave all of this alone. So this is, why did she first enroll in Medicare? Her age, she reached 65. Is she new? No. And this deals with Medicaid, not an issue for this patient. She's not in an institutional setting, and she's not in a special needs plan. Okay, I hit calculate, and this is what comes up. I get a base score. I get a score for, the category 18. and I get a score for 137, and it gets added up. And I'm going to notate what that combination is, 1042, because we're going to do a little comparison here. Now, the next thing we're going to do, I'm going to add congestive heart failure, I-59. Alrighty. And I'm going to leave all this the same, and I'm going to recalculate. And look what happened. It added these. It added a condition interaction for diabetes and congestive heart failure, and another one for congestive heart failure and renal failure. And there are certain sets of conditions that when a patient has both of them, they get extra points in this risk factor score. Okay, and it's based on the costliness of treating those conditions. So that's an interesting kind of thing. Now I'm going to clear this, and I want to show you one other thing. It's really important in risk adjustment that when a patient has diagnoses that should be combo coded and the guidelines allow me to combo code, it's important that I combo code. And I want to show you something if I don't combo code. So this will not be correct coding. Okay. E11.9, diabetes without complications, and 18.4. Stage 4 chronic kidney disease. Now, remember the first one that I did was the 11.2.2, which is diabetes with chronic kidney disease, which was correct coding for this. All right, I'm going to again make her, I had her 75 years old. I'm going to calculate and look at the difference. I noted down the total score when I comboed was 1.042. And here our score is 0.845. And when that goes through the calculating that happens at the end of the day, after this is all into Medicare and they're calculating the funding for these plans, that will make a really big difference. So it's terribly important that we risk adjustment coders, when we can combo, we combo code. That's my little soapbox on that. All righty. Now we're moving on to trumping, and trumping is something that influences also that final risk score that determines the funding that the insurance plan is going to get from Medicare. And so what is trumping? If we look, this is a trumping table, and it's from 2017, but that actually is fine for what our purpose is here. And let's take a look. We look at the headings here. First column is the numbers of various categories. Second column is the diseases that fall into those categories. So category number 8 is metastatic cancer and acute leukemias. And then the third column says, then drop the disease groups listed in this column. And I'm still not sure what that means just from reading that. Okay, so we're going to look at an example here. And we're going to look at HCC 17, which is diabetes with acute conditions. And what this is telling us is that if a patient has diabetes with acute conditions, as well as conditions that fall into either category 18 or 19, and 19 is diabetes with chronic conditions, that the acute condition is going to trump or overpower that chronic condition. It will replace it, in essence, when those risk factors are scored. And so let's take this another step and let's look at real codes. So we're going to look at E08.11 and E08.21. Okay, and these E0811, diabetes mellitus due to underlying condition with ketoacidosis with chemo. We're talking about a patient who is very ill in this code, and that falls into category 17. And then E08.21 is more of a diabetes with an everyday chronic condition. Diabetes mellitus due to underlying condition with diabetic nephropathy. This is something the patient is living with. It may be quite challenging, but it is not of the severity of being in a coma from diabetes, all right? And so when it's time to do these calculations, the diabetic nephropathy code disappears and it's not factored in. And this is trumping. E08.21 in category 18 is trumped in category 17 by E0811. And here we are back in Find a Code. And here I've got these two codes, E0811 and E0821, ketoacidosis with coma and diabetic nephropathy. And I've calculated, I get my base, and look at here. It only gives me a factor for HCC 17, and 18 is gone. And then it gives me this note, HCC 17 took precedence over HCC 18. And so it's like it's included in there, okay? And it reminds me of bundling, say, in a surgical package, where this gets included within that score. So do we as coders have to take this into account? No. If things are getting trumped, we're going to code both of those things, the trumper and the trumpee code, so to speak. And this is something that happens at the end of the road, but I think it's really good for us to understand these aspects of risk adjustment. It helps us to do a better job when we understand the whole picture. Okay, moving on. Some risk adjustment models. Okay, we've got Medicare Advantage. That's what we've been talking about, and that's what we really are focused on in this particular presentation. HCCC, that just happens to go with it. Okay, this is a Medicare Advantage plans. So a patient who is in a traditional Medicare plan with maybe a supplemental, this doesn't apply to them. This applies to the charts of patients enrolled in Medicare Advantage plans. And these plans use HCCs based on conditions, and they may also use RX HCCs based on medications. And that kind of makes sense to me because some of these Medicare Advantage plans include drug coverage and some don't. And that probably is the driving force behind that. Commercial, what's commercial? That's the Affordable Care Act plans. Yes, Affordable Care Act patients, their charts get coded through the risk adjustment methodology, but they only use HCCs. So a code like hypertension that is only an RX HCC will not be picked up by a risk adjustment coder coding for the Affordable Care Plan. So we really have to keep our wits about us as to what we're coding and what we should and shouldn't pick up. Medicaid is also a risk adjustment model. It's kind of complex for a number of reasons. We're just not going to go into that in any detail here. And how do you know what you're doing? You go back to your project guidelines. They tell us, what are we coding? Are we only coding HCCs? Or are we coding both HCCs and RX HCCs? They're one of our main tools. Okay. Here's our language, and we have lots of language. We have so many acronyms. But these are three key things. Data collection, period. You might remember when I first opened, I talked about how in risk adjustment, we code for a date range rather than an individual data service. And so we call that the data collection period, the date range for acceptable dates of service to code. And the project guidelines tell us what the specific date range. So your chart may have dates of service that are before your date range, and they may be after. And that's fine, but you don't code those. You skip right on by them. You just keep moving and get to those notes that are for your acceptable date of service for that project. And a lot of the time, not always, but a lot of the time, risk adjustment is looking back to project future costs, to help project future costs. It's data that they use. Mapping tool, I mentioned this a bit. It's usually a spreadsheet that an HCC coder uses to determine if a given code maps to an HCC. We're going to look at some in a bit, so this won't be quite so vague. And codes in a mapping tool are going to vary based on the population that is being serviced here. So if you think about the difference between the population in Medicare and the Affordable Care Act, Medicare, you have a population that is mostly 65 and older. And once a woman hits, 65, she's well past childbearing age. And so pregnancy does not get coded. It does not map when you're coding for Medicare, the Medicare Advantage plans. However, if you're coding for the Affordable Care Act, you're doing commercial coding, guess what? You're going to be picking up those pregnancy codes because many, many women who have that coverage are of childbearing age and will become pregnant. Substantiation. This is key. When doctors write up their notes, um, sometimes they use history of in a different way from the way it's used in coding. When we think of history of, we think of it as total history. It's done. It's over with. Patient has it's no longer in existence. Sometimes a doctor, when they write it, means yes, it happened in the past, but it's still going on. And so a risk adjustment coder has to dig into that chart to find validation that a given condition is active on that data service that you're coding. And one of the words we used for this is substantiation. We also use support. And where do we find that substantiation? Right in the provider's documentation. That documentation is just so important to us. And that's how we know that condition is truly current. And we have these two acronyms that we use to help us to really find those items in the chart that will substantiate conditions. One of them, we use the word MEET, M for monitor, E for evaluate, A for assess, and T for treat. MEET, pretty simple. Another one that we use is tamper, T for treatment, A for assessment, M, monitoring, medicating, P for plan, E for evaluate, and R for referral. Alrighty, some of the same words are there. Monitor, I believe we have evaluate, we have assess, we have treat. Tamper includes a couple other words, but the concepts are pretty well included in MEET as well. So when we are reviewing a chart for substantiation, we keep these acronyms in mind. And we all know if the doctor didn't say it, it didn't happen. And I've had charts sometimes where I'm about as sure as I can be that a patient has a given diagnosis on a certain day when they saw the doctor, and I need MEET, and the doctor didn't write anything in the chart to give me that MEET, that changes how I code it, or I may not be able to code it at all, depending on my guidelines. And so risk adjustment coders, we really have to keep this in mind. If the doctor didn't say it, it didn't happen. So we're going to look now at some examples of the kinds of things that we can use to substantiate or support, validate that a condition is active. And I'm going to use tamper as the base for this. Okay, so T is for treatment. An example, surgery, or a decision that the patient will undergo surgery. Procedures, it could be as simple as an injection, or it could be more invasive. Therapy, physical therapy is a good example of that. If the provider orders durable medical equipment to help a patient with a condition, that's another good sample of MEET. Assessment, we could have a statement, might find it in the assessment portion of the note, might find it in the history of present illness, might say the condition is stable, very simple. But this confirms this is a real condition happening now. condition is improving. Another could say it's worsening. And they could also give way more detail than that, and that's fine too. We'll take as much as they give us. But that kind of a statement is enough. Monitor and medicating. For monitor, if they order pertinent labs, not any old labs, but labs that pertain to the condition, or if they review lab results, recent lab results, or maybe they're looking at how they're trending over time, that's good meat. If they order medication for the given condition, or they may say diabetes is well controlled with insulin. I love that because here the doctor is linking the condition with the medication. That's good meat too. Planning, deciding how the physician's going to manage the condition. Doctor's not going to plan how to manage a condition that the patient doesn't have. So you've got good meat going on there. Evaluate. Physical exam is like gold when it comes to meat because the doctor is literally looking at the patient and making observations, feeling that patient, examining, probing, listening with the stethoscope. And so that gives us that can give us really good information, really good validation. Referral. A doctor's not going to refer a patient to a specialist for a condition the patient doesn't have. So, these are all examples. There are others, and you kind of never know what you're going to find. You're on a little hunt there to see what's there that will validate that that condition is active. Promised, here we are with a mapping tool, and I'm going to show you how to use it. It is a spreadsheet. It's just like using any other spreadsheet, and I'm sure many of you, probably most of you, know how to search in a spreadsheet, but just please bear with me because we could have some attendees that are not familiar with this. We're going to start with Control F. We get this window, we type in whatever code we're looking for without the period. Okay, we click on Find Next. It'll take your cursor right to the code, verify that your description is correct, and then you're going to travel over here, and you see these numbers? These numbers are the numbers for your category, and these numbers tell you that this code does in fact map. A lot of times you'll see yes in addition to this in other columns. Or you may just see the yeses and not see the numbers, and it just depends how it's presented to you. But that's the clue. When you see down here blanks, that means these codes down here are not, this is for RxHCCs. So these are not RxHCC codes. So, but that's how you find it. And I want to show you now, you can get a mapping tool. You can download it yourself. It's publicly available. So I'm going to go to Medicare's website. I'm going to go to mappings. You see it's for lots of different years. So you want to pick whatever year you need. I'm going to go with 2020 right now. And then I need to pick final mappings. And it comes up as a zip file. And then as soon as it's ready, I open it up. I select the Excel file. And here we go. Here is our mapping tool. So I'm just going to do a very simple search. I always like to highlight that first column. You don't have to. So I do a Control F. I'm going to look for I-10. I'm going to click on Find Next. See how fast it took me there? There immediately, I like to highlight the row. I look across. I say, oh, these are blank. Remember we said earlier, I-10 does not map to any HCC. So here you see it visually happening, but here it is. Here's a number in the RxHCC category, so it maps there. And here you see your no's for the HCCs and your yes for the RxHCCs. So that confirms for me that this in fact does map. So that's your mapping tool. Not that tough a thing to use. Alrighty. So. And now we're going to talk about HCC Coders tools. We have quite a few essential tools. Some of them, this is just 3 of them, are first off and foremost the medical record. This is what the doctor wrote. the chart document about whatever happened when the provider was face to face with that patient. And this is our foundation. Without this, we're out of business. We just can't do anything without it. Project guidelines. I keep saying project guidelines, but they could also come from a company rather than it's project specific. Just depends where you're working. And these guidelines, we coders, we love rules, and in HCC, we have rules on top of rules on top of rules. Okay, we've got our project or company guidelines we have to apply. We've got ICD-10 CM guidelines, and CMS has HCC guidelines. Now, the CMS HCC guidelines tend to be very much in sync with the project guidelines. The project is going to tell you what CMS requires, okay? But the insurance companies do have some latitude on certain things, and so they make some decisions that impact how much risk they're taking relative to a final audit that will happen on what all gets the codes that get submitted. And that's on them, that's their decision. Sometimes their guidelines don't quite match ICD-10 guidelines. And then you go with the company or project guidelines. They are the ones, they trump the rest of them, okay? And then, of course, ICD-10 CM code book. And for those of us that are working in the field, coding clinic is an essential tool. It is every so much as binding as the code book and all the guidance that's in there. The coding clinic people submit questions and we get clarification through that. And so it's important to have an awareness of coding clinic. Now, if you're a CPC student, you haven't gotten your CPC yet, you don't need to think about coding clinic. But if you're working in the field, then coding clinic is really essential. You're taking the chance that you may code incorrectly if you're not using it. And then a really important piece of this is we must use the ICD-10 CM codes and guidelines in effect on the date of service that's being coded, not on the date that I code the chart. It's okay, I'm coding right now from 2019. And so I need to be using the codes that were in effect on those dates of service. And so sometimes I need to use the 2019 code book. I have an announcement here. And hopefully we all know this, but just in case anybody doesn't, new ICD-10 guidelines go into effect, this is every year, on October 1st of the previous year. So I'm coding 2019 right now. Once I hit a date of service that is October 1st, I have to shift gears into the 2020 code set and guidelines. And that's a bit of a challenge. And you have to have your wits about you on that. Okay, so what do HCC coders do at work? I used to wonder when I was a coding student, I would hear about this. I said, well, how does it all happen? And so we're going to go through some of what we HCC coders do, and we're going to do some exercises to get a little bit of practice in just what we do. And the first thing that we do is we audit the record. And so, audit it, there aren't any codes there yet. What are you going to audit? Well, we audit what the doctor wrote, and we make sure that it is compliant with CMS requirements for risk adjustment coding. There are certain things that have to be in place, and these are reflected in your guidelines. They'll be there for you, okay? So before I touch a code, I've got to check for all these things. I have to see, is this medical record for the correct patient? You probably will have a portal where you will access the charts that you'll be coding. And as you bring up a chart, it will tell you what patient you are coding, and it'll probably give you a second identifier like a date of birth. And you need to review your record and make sure that you're coding for the correct patient. Every now and then a mistake happens in the scanning, and it includes documentation for 2 patients or 3 patients could happen. And we can't code that way. We just can't. That is not acceptable at all. And so your guidelines will tell you what to do about that. But you don't want to have, say, a 500-page chart and hit page 499 and find a different patient. So part of my work process is I look at every page of my chart before I code anything to make sure it's all the correct patient. That way I don't waste time doing a lot of work that I just have to take out. Do I have dates of service within the data collection period? Remember I said you could have dates of service that are before or after your data collection period. Normally you do, and I see one and I move on. This I need to do for every chart in every record rather in that chart is the provider an acceptable provider type. And we'll be talking about who is and isn't acceptable in a bit. A lot of acceptables in risk adjustment is the note signed by the provider. That's the provider saying, this is real. I saw this patient and these are my conclusions. So this is a really important piece of this. And then there are certain guidelines as to how that signature is done. And so does it comply with those? I'm checking whether the place of service is acceptable. I'm checking whether there is evidence of a face-to-face visit in a complete note. Face-to-face visit is a real essential in risk adjustment coding. We've got to know that the doctor physically was in the room with the patient. We're not talking telemedicine here, okay? We're talking the doctor physically there, and you need to see evidence of that in your note. And there's certain things you'll look for that tell you, yeah, he was there. So I check all these things, and if it's a go, I go. If it's not, my project guidelines will tell me what to do. It may be that I just reject the chart. I put a chart level flag that says what's wrong, and I push it back. Okay, or it may be that I code it anyway, and I put a flag on it that say, hey, we've got a signature problem, but signature problems can get fixed when it's outpatient. And so you put a little note, a flag on there that tells the insurance company that there's a signature problem here, and the insurance company can take it from there. All right, we are now going to practice doing this audit for compliance with HCC. Okay, so I go to my portal. I see, okay, here's my patient, Susie Sunshine. Of course, this is a fictitious person. Her date of birth, 9/23/47. My guidelines tell me that my data collection period is 1/1/2018 through 12/31/2019. So I'm coding 2 years worth of documentation. And this is part of a Medicare HCC and our XHCC project. Okay, those are essential for me to know before I do anything. And this is just one note in this patient's chart. No doubt there are others, and I will have gone through and checked. I don't have other patients in here and all that kind of thing. But now I'm ready to look at this chart. So I need to be sure that I've got the same patient. So I look and I have 2 identifiers. I have Susie Sunshine, that's a match. Date of birth, 9/23/47, 9/23/47. Bingo, that's a match. Alrighty. What else do I have to check? I need to make sure I'm within the data collection period. Data visit 9/29/18, and that falls right within these dates. So that's a match. Alrighty. I need to check the signature. This is electronically signed by, and we haven't talked about all this yet, but this is verbiage for that says that the provider is authenticating that this is a valid and true statement as to this visit. And then we have the name of the doctor, Marcus Feelgood, another fictitious doctor, a credential. We always need a credential. And the date is optional. If we have a date, it needs to be within 180 days typically, and this is fine. This is just a few days later. So we're good on that signature. Okay, so our basics are covered. Let's see if we have a complete note here. A complete note includes a subjective information. I was going to say section, but it doesn't have to be a section. It can be in any format, but we need subjective information. We're looking for objective information. We are looking for an assessment. We're looking for a plan. So we look in the beginning. we find subjective. Chief complaint, patient says, patient is talking here. That makes it subjective. Patient says that her lower extremity swelling continues to bother her. Good subjective information there. Okay, gonna look for objective. We have a data review. The physician is reviewing objective data. He looks at a lab, he looks at an echocardiogram. So that is objective. Okay, the physician also does an exam, and an exam is objective. Objective is the physician evaluating, looking at something to see what's there and see what's going on. And so these are things that a physician uses to arrive at his or her conclusions. So our objective is good there. Okay, now we have an assessment, and it's labeled assessment, so that makes that part really easy, huh? So we've got an assessment, and do we have a plan? That's labeled plan as well. So that part is good. So this is a good note to code. Okay, so now I can put on my HCC coder hat and get about the business of coding this chart. Now we're going to talk a little bit about acceptable and unacceptable signatures. Um, Types basically are either handwritten or electronic. Those are both acceptable. And in handwritten, you can have the name written or you can have the initials. It may or may not be readable, okay? But you gotta have it there. And and you have to have credentials with the signature or somewhere in that note. Unacceptable, and this would be written, not typed like this. Mary C. Smith, MD, or the initials MCS, MD. Okay. Another type is electronic. We just looked at an electronic signature. Has to include credentials, or again, if it's not there, needs to be somewhere in that note. So we need to have authentication, and that's what we call the authentication verbiage. We saw electronically signed by, could simply see signed by, approved by, finalized by. There's a long list, and you'll be given a long list of acceptable verbiage for that authentication statement. Okay, so you need that, you need the doctor's name, you need the credential, and then the date is typically optional in these. And it needs to be password protected and used exclusively by the individual physician. So would not be appropriate if I worked in a doctor's office for me to go, say I had the physician gave me his sign on and I went in and I signed for that physician. That would not be appropriate at all. That physician is the person who has to authenticate that this is in fact a valid description of what happened in that appointment. So now we're going to look at some unacceptables. Sometimes you just see a typed name, nothing handwritten with it, no electronic verbiage with it, just the name. That will not do unless it gets somehow authenticated by the provider. Okay, you could have a non-physician or a non-physician extender, like a medical student, and they can see patients and their work can be risk adjustment coded, but that needs to be co-signed by an acceptable physician. Unacceptable, provider signature without credentials. Gotta have the credentials. Okay, but it is acceptable. It is acceptable if that name is linked to provider credentials somewhere else in the note, and sometimes just in you may have practice stationery that lists all the physicians with their credentials, and that's fine. If it's not within the signature, it's fine. Just has to be somewhere. And just for fun, I brought in a couple examples. These are electronic. Now this first one, electronically created by, that may or may not be valid depending. Electronically signed by is, we got a credential here, and this gives us the date. Usually the electronics have the date in them. Simply signed by is fine. Okay, but here I don't see a credential. And so that's a problem. And if there's no credential elsewhere in the document, I would need to flag that. Sometimes you get a hybrid. You get a handwritten signature and you get electronically signed by. That's fine, you know. And then sometimes you just get a handwritten signature. And of course, if you have a handwritten note, you're going to have a handwritten signature. Um, this one especially, I sure hope there's a typed name somewhere so that I know who this provider is. But they come in all varieties, and this is what some of them are like. So now what happens next? Next, we code the record. All right. Finally, we get to code. So we follow ICD-10-CM guidelines, HCC, and project or company guidelines. We abstract diagnoses from the provider documentation. So I read through and I say, hypertension, and I do what I need to do with that. I find the most specific code in the ICD-10-CM code book, and I follow coding clinic guidance if applicable. I check to see if the codes map. I check for substantiation. I think tamper and meet. So I look for in that documentation to see if they have been substantiated. I check if I need to enter flags with the codes. And I follow the company procedure for submission of my codes, whatever that is. After this is all done, an auditor is going to take a look at least some of my work. And hopefully I get feedback when that happens. And it's important that I go look at that, because that's one of the best ways that we can keep growing as coders and learning, because you don't want to keep making the same mistakes, and nobody knows everything. And so your auditor, is going to know things that you haven't learned yet. And so you also want to keep an eye out for any feedback from an auditor. So we're back to Susie Sunshine. And now, you know what we're going to do? We're going to work on some coding. Okay. And Mrs. Tracy, would you like to read this for us?
Absolutely.
Thanks.
Date of birth 9/23/1947. Date is 10/29/2018. Chief complaint, patient says that her lower extremity swelling continues to bother her. HPI. Patient is here today for evaluation of her bilateral lower extremity swelling. The swelling responded to hydrochlorothiazide. Data review. I reviewed her lab and echocardiogram. The patient does have moderate pulmonary hypertension. Exam. Patient is in no acute distress. Assessment. 1. Bilateral lower extremity swelling. This is resolved with diuretics. It may be secondary to problem number 2. 2. Pulmonary hypertension. Etiology is not clear at this time. Will work up and possibly refer to a pulmonologist. Plan. Will evaluate the pulmonary hypertension. Patient will be scheduled for a sleep study. Electronically signed by Marcus Philgood, MD, 11/01/2018.
Thank you, Mrs. Tracy. Okay, first thing we got to do, we got to code it. And I'm going to start with the assessment. And we can start anywhere. My personal preference is the assessment, because a lot of times I'm going to find meat here, at the same time. So, a meat can be anywhere also, but the assessment frequently is richer in details, like the specificity, as well as meat that will support it. And so I like to start in the assessment and then I work my way back up. So the assessment, 1, bilateral lower extremity swelling. Swelling is a symptom. It's not going to map. And then we read on, this has resolved with diuretics. HCC coding, we're not going to code resolved in the outpatient setting, in the physician office setting, okay? And then maybe secondary to problem number 2, so let's look at problem number 2, pulmonary hypertension. Boom, I've got a diagnosis. Okay, there's something I can code. Etiology not clear at this time. We'll work up and possibly refer to a pulmonologist. And my HCC coder is saying, ooh, I've got some meat there. And then plan will evaluate the pulmonary hypertension. It's repeated. Patient will be scheduled for sleep study. That's not very pertinent, but it's there. And then we're going to go up to the top. And just in case, I need to look at the whole note, because there can be something tucked anywhere. So, okay, the chief complaint, nothing there. HPI, nothing that's going to change my coding. Data review. Okay, it does say moderate. So I'll need to check. I don't think that ICD-10 is going to have a code for that specificity. Alrighty. So looks like we're ready. Moderate or probably just pulmonary hypertension is what we're going for. And we got to code it. That's our first step. Got to have a code before we can find out if it maps. So in my trusty ICD-10 code book, I go to the alpha index. I go to hypertension. I travel down to pulmonary. It gives me a default code of I2720. This width, none of these apply, so I'm going to go into my tabular, my category I272. Here's I2720, pulmonary hypertension, unspecified, and right underneath it, pulmonary hypertension, not otherwise specified. So that's what I'm going for. Okay, so there's our code. And I do want to just point out these notations are scattered throughout the ICD-10 code book. And when you say AHA colon, and then you see information, this is telling you that there is a coding clinic. Here it's pertaining to this category. And so if I'm not sure how to code something, I always go see, is there a coding clinic on it? Because sometimes there may be, and that can help. This tells you what coding clinic. So 2017 fourth quarter, pages 14 to 15, 2014 fourth quarter, page 21. And we're not going to go pull that. It's not really pertinent to this particular exercise. But I just wanted to point that out for you so you know where you can find references to it. Okay, so we have a diagnosis. What's next? We got to see if it maps. So we've got our mapping tool. Going to do a search. It takes me to I2720, description, pulmonary hypertension, unspecified. That's good. And I see a yes for HCC, and I see a yes for RHCC. So we have a match. This does in fact map. So we're in good condition for mapping. So what's next? We got to find the meat. Where is the meat? Now, right now, we're not following any particular guidelines, so we're going through all the steps. In a real project, you may not need meat because this is chronic in the assessment, but right now, we're going to go find the meat. Okay, so I look it over, and I kind of gave you a little hint when I found the diagnosis. I said I saw something in the assessment. And you know what I saw? Now we're going to go on our hunt to find some meat in this note for pulmonary hypertension. So let's start with the data review. And here I have the patient does have moderate pulmonary hypertension. Now, who's talking here? Patient isn't talking. This is the doctor talking. When the doctor says the patient has this condition, that's the best meat you can get. We call that the provider's active voice. The provider is literally telling us the patient has this condition. We don't have to look any further for meat. We're going to for the purposes of learning here, but this will work. This is ample meat for us. But I'm going to keep looking. Exam doesn't help me. Assessment, I'm not going to worry about that. And here I've got some more meat. This provider is planning to do a workup on pulmonary hypertension, probably to figure out the etiology. But this tells us this is a real condition. Possibly refer to a pulmonologist. Not going to refer to a pulmonologist for this condition if the patient does not have it. So there's more meat. We only need one source of meat in any code at any time, but it's always nice when we have more. I like that. And for here, I wanted to really make sure you saw more. And here it is right in the plan. So the plan is to further evaluate the pulmonary hypertension. Doctor's not going to do that if the patient does not have the condition. So there's 3 good sources of meat in one note. That's heaven for a risk adjustment coder. Okay, so we got the meat. This is ready for code submission. Wouldn't need any flags. This is done. It is now going to take us through an exercise, a series of exercises actually, where we're going to practice finding meat. Mrs. Tracy?
Okay, thank you so much, Miss Shirley. All right,
Welcome.
here is our first exercise. So the diagnosis is going to be atrial fibrillation and hyperlipidemia. And this doctor's providing these meds, Crestor for hyperlipidemia and Coumadin for anticoagulation for the AFib. So go ahead and tell me, where do you think does this documentation have meat and where can we find it? So first we'll start with the atrial fibrillation. So is there meat for atrial fibrillation? What do y'all think? Well, let's go ahead and scan this med list here. And if we look under that med list, it says that Coumadin is being given for anticoagulation for the AFib. So definitely there's our substantiation right there for the AFib. Now let's look over at hyperlipidemia. And do we have meat for hyperlipidemia? If you said yes, that is correct. So yes, we have the Crestor is being prescribed here for the hyperlipidemia. So this is definitely great meat, and the provider is linking these conditions with those meds, okay? All right. So those meds are, again, I'll just say that again because I may say that backwards, but the provider directly linked these meds with the conditions, okay? So great job, everybody. Let's move on. I have another exercise for you. Okay, our diagnosis here, same. We have atrial fibrillation and hyperlipidemia. The meds for this patient here are Voltaren gel, Coumadin, and Crestor. And the plan is continue Crestor and Coumadin and to order a lipid panel. All right, so what do you all think? Do we have meat for either one of these diagnoses here? So let's go ahead and see. So if I look for atrial fibrillation, I really don't see too much going on here to substantiate that. But when I look at hyperlipidemia and I see in the plan that this physician ordered a lipid panel, that is my meat for the hyperlipidemia. So we can go ahead and check that off the list. Now, if we look back up there at the med list, um, you know, you on this, it's kind of tricky. You really have to refer to your project guidelines. The project guidelines, if they so project guidelines tell you if you can use meds for meat when the provider did not link any medication to a condition. So basically, you just need to refer to the project guidelines on this to see if if the provider doesn't directly link a med to that condition or that diagnosis to see if you can use it as meat, okay, to substantiate that. So really, again, it just depends on the project guidelines. So great job on this one, coders, and let's move on. I have another one. Okay, the diagnosis here is hypothyroidism. And we have no meds that are listed. And the only thing under the plan is that a lipid panel was ordered. So what do you all think here? Do we have meat in this scenario? Yes or no? What do you think? Okay, so I'm going to say no, we don't. We don't have any meat. There was no meat found here. Now, you have to follow on your project guidelines on this one on whether you're going to code the diagnosis with a flag or not code it. So again, just always know those project guidelines. You need to follow those, but in this case, we do not have any meat. Okay. All right, and I believe I have another one for you. Okay, so where's the meat in this one? So we have our diagnosis. We have type 2 diabetes, um, and we have morbid obesity. The meds that are given, we have insulin, and the diabetes is not well controlled, and Lasix. The BMI is 42.0, and the plan is to refer to an endocrinologist about the diabetes and discuss with the patient the need to lose weight through reduced calories and exercise. So let's go ahead and begin with our type 2 diabetes. Do we have meat to support our type 2 diabetes here? What do y'all think? Type it in the chat. Okay, well, if you said yes, we do have meat here. You look in the med list, insulin is given, and it's directly saying there that the diabetes mellitus is not well controlled. So definitely have meat for our diabetes. Now, what about that more? And also, if you look down in the plan, we also have further meat for this, that the patient is being referred to an endocrinologist for the diabetes. Okay. Now, let's go ahead and go to our second diagnosis up there, morbid obesity. So, do you think we have meat for morbid obesity? Look at the mid list, look at your plan. What do y'all think? Well, if we look, first of all, the BMI, it says the BMI is 42.0. And not only that, but also in the plan, we have that there was a discussion with the patient, sorry, a discussion with the patient for the need to lose weight through reduced calories and exercise. Okay, so we have a BMI, we have it in the plan, and so definitely this does give us the meat for the morbid obesity. So how'd y'all do on that one? Make sense? All right, all right. Well, Miss Shirley, I think they did great, and I'm going to hand it on back to you.
Thank you, Mrs. Tracy. Think they did great also. And thanks for a great discussion on those. And guess what's coming? We're going to get ready now to do some practice coding as HCC coders. And so we're going to try to keep calm and follow those rules. We're going to be compliant with our guidelines and regulations. So I hope you're all ready to do some HCC coding. You're going to put on your HCC coders hat, and we're going to start with talking about our guidelines for the webinar. And Mrs. Tracy is going to take you through some things to remember.
Okay, thank you so much. All right, some things to remember. We need to make sure that this is the correct patient, as Ms. Shirley talked to you about earlier, of the importance of that. So we need to really make sure this is the correct patient. Um, Also, that the date of service is within the data collection period. Also, that this is a face-to-face encounter and that there is a complete note. Also, that it is the provider type is acceptable. We have an acceptable provider signature, an acceptable place of service, and we're going to code the diagnoses, map the codes, check for tamper if required, and add flags if needed. All right, and so for the purpose of our risk adjustment model, we're going to code Medicare HCC and RX HCC, and we're going to code all diagnoses that map to the HCC and or the RX HCC.
Thank you, Mrs. Tracy. And here we go. We're going to talk about some acceptable document types. Progress notes from an office visit with a physician. These include SOAP notes. They could be in the format of a letter. They could be handwritten. Consultation notes. You see them mostly when it's in a doctor's office, although it could be a referral to a specialist. Inpatient discharge summaries and pathology reports. And these are just some. There are many other types of acceptable documents, and you will find those in your guidelines. So you're going to follow outpatient guidelines for all document types except the inpatient discharge summary, and you will follow inpatient guidelines for your discharge summaries. And as I said, this is a sampling. It's not a comprehensive list for HCC coding. And we have some unacceptable document sources and types. And some unacceptable sources are records from a skilled nursing facility, diagnostic radiology, freestanding ambulatory surgical centers, alternative data sources like a library, unacceptable physician extenders like a nutritionist, DMEs, durable medical equipment, unacceptable types of medical record documentation, superbill, physician signed attestation, List of patient conditions, just a list. Sometimes you see that in a note. That's not quite enough. Diagnostic report that has not been interpreted, and any documentation for dates of service outside the data collection period. Acceptable provider types, and this again is just examples. Physician credentials, including MDs and DOs, physician assistants, nurse practitioner, they have an abundance of different credentials, licensed clinical social workers, not any social worker, they have to have that LCSW credential. Physical therapist, not a physical therapist assistant, must be the physical therapist. And as I said, this is just a sampling of the acceptable provider types for HCC coding. And here's the master list, okay? And you see it, these are all different specialties that are acceptable, and some things that you might not think of: certified nurse midwife. We could code from that kind of report. We're not going to see it in Medicare, but you could see it if you're coding for commercial. Nurse practitioner, psychologist, audiologist, lots of kinds of specialties besides the doctors and the nurse practitioners and the physician assistants. So every now and then you just need to look at this to be sure that a given provider is, their specialty is on this list. Chronic conditions, we need to understand that there are differences in how we code chronic conditions from acute conditions, and typically you will get a list of these are the chronic conditions that you are to code as chronic for your project. And so for this project that we're going to do during this webinar, these are our chronic conditions: diabetes, CKD, hypertension, asthma, hyperlipidemia, COPD, and congestive heart failure. If a condition is not on this list, we're going to code it as acute. Your real list might be a good deal longer than this in real life. Okay, I have simplified this just for the purpose of you're getting some exposure to what this kind of coding is all about. So it's just this little list of chronic conditions for this project that we're doing. And this reiterates what I've just said. Okay, guidelines on tamper. That's our substantiation or support. And you see it's organized according to whether a condition is acute, chronic, or certain statuses. And I'll go into that in a moment. Acute conditions, we always need tamper. Okay, no matter where it is in the note, we always need tamper. Chronic conditions, it depends on where it is in the note. Okay, we don't need it when it's in the assessment or plan, when it's in the physical exam, when it's in the history of present illness, or when it's in the past medical history. We do need tamper when it's in the chief complaint, the problem list, or the review of systems. Now, there's certain status. A status is something that it's something like an amputation. Okay, a patient lost a limb, a leg was amputated. That leg is not going to grow back. And so that patient has a status of amputation. Sometimes you'll have another status code is the patient had an old heart attack. That's a status code. A patient has had a kidney transplant. That's a status code. There are things that aren't going to change. There are some others that are acute. That's why the sum is here. Something like if a patient had a colostomy, they can be reversed. And so we need to, that is a status of having had a colostomy. But if it's been reversed, we're not going to pick it up. We just pick it up like everything else if it's current. All right. If we find a chronic condition and it has to have tamper, it's in the problem list, okay? And we need tamper for it, and there is no tamper. There's nothing that pertains to it anywhere else in the note. Nothing tells me that, hey, this is in fact a current condition. We're going to append a T flag for tamper to that code. Okay, tamper's missing for a chronic condition, T flag. Now, an acute condition always needs tamper, and if we don't have tamper, we're not going to code it. We're just going to move right on, leave it in the chart, okay? But we will capture chronic conditions. If they're missing tamper and they need tamper, we just add that T flag. And that notifies the company that there's a problem with this code and they can't send it on to CMS, but they may want to know about it. They can use it as a basis for some provider education. And this is our list of flags that we're going to use for this webinar. So if we run into certain problems, we will append a flag. So the first flag is T for tamper deficiency. So if I have a code that needs tamper and it's not anywhere to be found in that chart, I'm going to append a T to that code. S for provider signature deficiency. So if the signature is missing, or if I just, if there's some other problem with it, I will attach an S to it. H is for no HCCs or RxHCCs found. So you've gone through the entire chart and any diagnosis in there is not a condition that maps. I have to put an H on that chart because there's nothing to code. D, if there's no data service within the data collection period. Whoever scanned the chart got mixed up and pulled earlier dates of service. So I put a D on that chart and then the insurance company fixes that. RP is a reject based on patients. So either I open the chart and it's the wrong patient, or commingled is a term that we use meaning more than one patient's in that chart. We don't want to deal with that. We're getting into HIPAA trouble if we do that. RD is rejection based on documentation, means there's no acceptable documentation type in that chart. Maybe it's all skilled nursing facility that I can't code from, or maybe it's all ambulance reports, can't code from that either. Okay, so that is an RD flag on the chart. So flags give an alert to the carrier that there's a problem. Some may be used as a basis for provider education, and signature problems can be fixed with a provider attestation. So some more on tamper. I mentioned earlier, some status codes never require tamper. Old MIs, the amputations that map, not all of them do, and organ transplants. So in your handouts for the webinar, you have this document, an HCC coding worksheet. And I just created this so that you can track what you're doing and so that you don't get lost in the process because there's a lot of steps. So this gives me a visual as I go. In real life, do I use something like this? No, it just kind of happens. But while we're learning and while we're doing this process, you can use this. You don't have to, it's optional, but it's there to help if you would like to. So first column, you're going to write the words of the diagnosis. Second column, after you've coded it, you'll write the code. ACS is for acute, chronic, or status, so just put whatever letter applies. Location is the location in the chart. Map is does it map or not, Y or N. Is tamper needed, Y or M. Tamper, what is the tamper? You know, the provider said something or a certain lab or, you know, a certain med. And if you need to append a flag, what is that flag? So that's what this is for. And here's an explanation of it. Now, as we work on these charts, the initial check, remember way back when I talked about how we audit for compliance with the CMS's rules for, you know, what has to be in the documentation. That initial check for the patient, signature, data service, all that has already been done. Just assume that they're all fine. Okay, we're going to work on coding, mapping, tamper, flag. That's going to be the focus of what we're doing now. So here is our first scenario. We're going to work with scenarios and then with very simplified charts. And Mrs. Tracy is going to read this one for us. Mrs. Tracy?
Okay, here's our scenario. Mrs. Green, a 42-year-old female, is seeing her medical oncologist for the first time since her diagnosis of breast cancer. The physician reviewed the pathology report, which confirmed carcinoma of the lower inner quadrant of her right breast. She has already undergone surgery, but the doctor recommends that she now receive adjuvant chemotherapy. Her he discusses the treatment, the risk and side effects with Mrs. Green. The patient consents to the chemo treatment. I'm sorry, trying to add words here. Okay, so coders, we got to code this. So go ahead. The worksheet that Miss Shirley just went over with you, you're going to use your worksheet and you're going to answer the following. You want to know what is the diagnosis and code. Is this acute or chronic or status? Know the location in the chart. Make sure you put it there. Does it map? Um, does it have tamper? And is a flag needing to be appended? Okay. So we're going to give you 2 minutes on this one to solve, and your time begins now. Good luck.
Okay, coders, your time is up. How did you do? Did you find it very difficult? Sometimes cancers can be kind of tricky. I hope you have your answer in the chat. And let's take a look at this. Going to look first for keywords. And we have a diagnosis of breast cancer. Our patient is a 42-year-old female. And it's really important we know the gender when we're dealing with breast cancer because it impacts your choice of codes. And we have some very specific uh, documentation here. It is carcinoma. That is a cancer of the lower inner quadrants. We've got the exact location of her right breast. We have the laterality. So we're going to make sure that we include all of that when we are selecting our code. So we're going to dig into the index. I go to the alpha index. It tells me to go to my neoplasm table. So here we have a clip of the neoplasm table. I look for breast. Here's breast. Now I have to find that location, lower inner quadrant. That was what we're looking for, lower inner quadrant. And this is a malignancy that is primary. And so I go to that first column, and here is the start of my code, okay? This dash and checkbox tells me this is not a complete code. This is the first 4 characters of it. So C50.3, I need to go to my tabular and find C50.3, and that's giving me malignant neoplasm of the lower inner quadrant of the breast. That's not the whole story, is it? It's a good part of it, but it's not quite enough. And this tells me I need more characters. So I go here and I see C50.31. Okay, malignant neoplasm, lower inner quadrant of breast, female. So I've got the gender. I still need to get the plurality, and I go to the next step, C5311, malignant neoplasm of lower inner quadrant of right female breast. Lower inner quadrant of right female breast. I'm always double checking myself with these. So C5311 is in fact our code. Did you come up with that one? If you did, well done. And if not, you will the next time. So I've gone onto my worksheet and I've put in my code. I already wrote whatever the words for the diagnosis. I put in my code, and this is an acute code. It was not on our list of chronic diagnoses, was it? So we've got an acute condition here, and location is not pertinent in this because we are dealing with a scenario rather than with a chart. This location column is about the location in the chart. So that's as much as we can do with this so far. We're not done yet. What do we do next? We got to check and see if this code maps. So here we've got a clip of part of the mapping tool. Does C50.311 map? Here it is. Malignant neoplasm of lower inner quadrant of right female breast. And I get a yes and a yes for HCC and RxHCC. So yay, it maps. We're in good shape here. Do I need tamper? Let's look at our guidelines. It is an acute condition, and the guideline for acute is it always is required. Tamper is always required. So we've got to go hunting for some tamper. All righty, so let's see what we can find. When I look at this, I see the physician reviewed a pathology report. A pathology report when you're dealing with a condition like cancer is a gold mine. You get all kinds of specificity there. And this pathology report confirmed that this patient has carcinoma, which is cancer of the lower inner quadrant of her right breast. Okay, so that's good meat. And we have a second source of good meat. The doctor recommends that she now receive adjuvant chemotherapy. And when we're dealing with whether cancer is current or not, if a patient's receiving active treatment, we're talking about active disease. And so we have two sources of meat here. Both are good, the pathology report and the recommendation for chemotherapy. And we're good to go on meat. We only need one of them, but we've got two. So do we need a flag? So this code is ready to submit, C50.311. So how did you do with the meat? I'll bet a lot of you got it. Okay, moving on. And Miss Tracy, can you read this one for us, please?
Yes, I can, Miss Shirley. Okay, we have date of encounter 9/14/2019. Chief complaint is chest pain. HPI, patient has been experiencing intermittent chest pain for the last week, but says she is otherwise fine. Past medical history, hyperlipidemia, diabetes type 2, cataracts, corrected surgically 2017. EKG done in office today shows no indication of history of a heart attack. Exam, CV, normal rate and rhythm. Assessment, angina, hyperlipidemia mixed, DM2, diabetes mellitus 2, well controlled. Plan, order nitroglycerin to be used PRN as needed for the angina. Instructed patient on its use. Order lipid panel to be done prior to next office visit. All right, coders, I believe, are we doing 3 minutes on this one, Miss Shirley?
Yes, this one is 3 minutes.
Okay. Good luck, coders. Your time begins now.
Go for it. And your time is up, coders. How was this one? Did you get them? I hope you did. Let's take a look and see if your codes match with ones that I came up with. I'm going to start. I have to figure out the diagnoses I have to code. And I'm going to look in the assessment, and I see angina, I see mixed hyperlipidemia, and I see diabetes type 2. Doesn't look like there's any complications with it. I'm going to look through the rest of the chart. Chest pain, that's a symptom. That's not going to map. Okay, there's nothing in the HPI that I would pick up. PMH, I've got a diagnosis, hyperlipidemia, but that's unspecified. And when I look down in the assessment, I have the specificity that this is mixed. So I'm going to go with mixed hyperlipidemia and code that. Diabetes type 2 is the same. Okay, and then we have cataracts. Doesn't map, but I just want to make the point that this was corrected surgically. So if it did map, then I would not pick it up anyway because it has been corrected. It's a historical. However, oh, wait a minute, I take that back. This would map because I can link that with diabetes. Ooh, okay, that's a combo. E1136. So I could accept that it's been corrected surgically, so I can't. If the cataracts were still active in the patient, and I had meat, I would need meat because that would not be chronic. Then I would be able to combo code those two, but I can't. So I'm looking for codes for angina, mixed hyperlipidemia, and diabetes type 2. So trust the alpha index, always trust your index. So I'm going to start with keyword angina, and it's not any further specified in my note. And so that's where I stop. And here's my default code, I-29. I go to my tabular, I-29, and angina, NOS, not otherwise specified. That is exactly what we have here. So I-29 is my code, and I jot it down in my form. Moving on, mixed hyperlipidemia. I'm not going to start with mixed, am I? I'm going to start with hyperlipidemia. Okay, and then I'm going to go down and I find the specificity of mixed, and it points me to E782. So I go to the tabular and I see E782 It's the category, but it is also the code, mixed hyperlipidemia. I'm sorry, that can't be the category. It's the code, mixed hyperlipidemia. We have all these different variations, and none of these happen to apply. Excludes one that doesn't apply, so that's our code. And we write it in here. Type 2 diabetes. I go under diabetes. I make sure I'm in the right type. Very important. I have no other specificity. It's not combined with anything in this note. Could be with cataracts if they hadn't been surgically removed, but they were, so I can't code that. So I need to code simply E11.9. Type 2 diabetes mellitus without complications, E11.9. So there's my codes. Okay, what's next? I got to check the mapping. So does I-29 map? Here it is, angina pectoris unspecified. Got a yes and a yes, so it does map. E782, does it map? Here it is, mixed hyperlipidemia, no, uh-oh. That's for HCC, but you know what? I keep going and I get a yes for RxHCC. So that maps. So I can do that one. E11.9, does that map? Here's the code, here's the description, and I got a yes and a yes, so that maps. So everything maps. Do I need any tamper? Let's look. If I look at my guideline, angina, we have figured out is an acute code. It's in the assessment, that doesn't matter. Acute anywhere needs tamper. So we look here and our guideline tells us tamper is always required. So yes, we got to find the meat. If we look at the chronic conditions, mixed hyperlipidemia and diabetes, not required. So we don't have to worry about meat for those. We may or may not have meat in our little chart there, but we need to have meat for the angina so that we can code that. So let's see what we got. When I look at this, I see in the plan, beautiful meat. Order nitroglycerin to be used PRN for angina. So the provider linked them. Bingo, I can use that. And then instructed the patient on its use. That's also good. So I've got good meat for that. So I can code that. Alrighty. So here's my coding. I-29, E782, E11.9. And you know, there's something about risk adjustment coding. Got to put this in announcement. This is big. In risk adjustment coding, sequencing is not part of what we need to deal with. I enter my codes as I come across them in a chart. I don't have to worry about what goes first and what comes next. Sequencing is not part of HCC coding. Truly beautiful in my view of the world. Alrighty, let's move on. So here's our chart finished, and this is what I would submit for this chart. Hope you came up with the same codes, or if you didn't, there you learned, so the next time you will. Alrighty. Now, here we've got, look at this. What is this about? We got a piece of a chart, med list from a chart, some vitals, signature, more signature. We're gonna do a chart demo. Okay, let me get set up and we'll be starting this in a sec. Okay, coders, I have up now a sample chart. Now this is fictitious, I made it up. It's a little simpler than what you see in, at work, but it's similar, it's pretty similar. And so I'm gonna go through this as a coder and I'm gonna code it. And over here, I created an Excel spreadsheet that gives me spots where I can enter everything as I find it. So it kind of simulates what I might be doing on a client's portal where I'm entering and submitting my codes. So we're just going to simulate what happens. So so you need to imagine in your mind's eye for just a moment, I've gone to the portal, I've asked for my next chart, this comes up, I compare the patient's name. I didn't put a patient's name on this, but patient's name, date of birth matches. And so I am ready to start to check this out. And what I like about this, I was able to open it up in Edge, and so I can do markings right on it. I can highlight and I can underline. That's great. Okay, so first, my data collection period is 2019 to 2020, so I'm in good shape that way. I have a provider. Again, we have Dr. Marcus Feelgood, and we have a credential MD. I'm going to browse through the chart, see what I have, make sure I've got face-to-face. That's really important. And none of this tells me I've got face-to-face. Well, actually, do I have some? Okay, this tells me I have face-to-face. Patient presents today. If that's all I've got, I can go with that. But I like it when I have an exam because I know the doctor then is with that patient for sure. Okay, so I do have face-to-face. I got an assessment. I have a complete chart from what I can see. I've got a signature. I have my electronic verbiage electronically signed by. I have the name of the physician. I have the credential. I have a date. Now let me go back and look up. Okay, my data service, 8/23/19. My signature date, 8/24/19. And so something that I like to do, and this is just me, I like to give it a little check mark. It says, okay, I checked that. I don't have to think about that again. Alrighty. Now remember I told you I like to start in the assessment, so that's where I'm going to begin. And I like to highlight as I go. So I see hypertension. I've got meat there. This is chronic in the assessment. Now I already put one in the data service. There are other things we need to put in. So let's talk about this. You always have to have identify your data service. I need to tell the provider type, and what that means is, and you'll be told how to do this. Okay, but I need to indicate, is this inpatient? Is it outpatient or is it in a provider's office? And you'll be given codes. So we're going to use P for provider office. We'll use I for inpatient, and we'll use O for outpatient should it be like an outpatient surgery. Now we're just going to do this one data service, so we're not going to be using those, but just to give you context. Provider ID, in some way you need to identify that provider with the chart, and your organization will tell you how to do it. Project I'm on now, we go after an NPI number. I'm just going to put in 5 numbers, okay, and say that's this provider's ID. I'm going to need to say what page I found the code on. That's quite important. Of course, what the code is. If it needs a flag, I put it in, and then I can put notes to myself or notes for my auditor should this chart be audited. Alrighty, so I'm in my assessment. I'm back there. I like an assessment. Okay, I have hypertension. That's a great, great code. I've set up my first record here. It is on page. I look up here and I see, okay, this is page 2. So I enter that. I enter my code, I-10. I don't need a flag. I'm going to document where I found it. Assessment and plan, page 2. That way, if this gets audited, the auditor knows right where I got it. Now, to save time here, I'm just going to copy these and put them down. This is more than what we'll need probably. Okay, so that's all set up. Sometimes you'll be set up such that you only do this once, and then you do the things that change, for each code. But sometimes you have to put them in every time. And so I just set this up so I would have to put in every time. But because it's this kind of format, I can copy and paste. You can't count. Normally, you would not be able to do that. Then what I like to do after I've coded it, I highlighted it. I know it's done. Morbid obesity. Does that map? Yes, I know. Now, I'm not going to have to go to the mapping tool and all that because I've done enough of this that I know these codes and I know that they map, or I know if they don't map. If you're new to this, you've got to do all that work. You got to go to your index, look it up, go to your mapping tool, make sure it maps. I can tell you morbid obesity does in fact map. Okay, it's on page 2. Code E6601. Do we leave? You know what? I'm going to go to find a code and just be 100% sure of that. And find a code, and here we go. Go into Clickadex, which is just like your code book. Okay, so this is the alpha index where I am now, and I'm going to go to morbid, And it is, okay, I was right there, E6601. Alrighty, so going back here, E6601 was correct. Don't need to put in a flag. That's also AP2. Now this is a chronic condition, and I want to continues to gain weight. That's not so hot, and it is linked to it, so it definitely is meat. I want to document the BMI. I'm going to check that out as we go. So I'm going to put question mark M in there, meat. Okay, and I'll use this if I have to, but I've got a BMI. I'm going to go after that. All right, so I got that, but I'm just going to put the little M in there so I know. Okay, moving on. CKD stable seen by nephrology last week. I've got great meat there. I don't have a stage. Can I do anything with that? I got to have a stage to code it. But look what I've got here. I have hypertension and CKD, and I know that they map. So I'm going to go up to my hypertension code, and I'm going to change it to I-12-9. That is hypertension with CKD. All right. So wow, so I got 2 and 1 in that code. And ICD-10 does tell us to document the stage. This would be coded N18-9, which does not map, so I can't do anything with that. All righty. Moving right along. Congestive heart failure. Again, I have good meat here for that. It's on page 2. And congestive heart failure, I-59. I don't need a flag. And it's AP2. Now, doesn't HTN, CKD, don't they also map with heart failure? They combo, rather not map, they combo. HTN, CKD, and congestive heart failure are a combo. So I'm not finished with this hypertension code yet. I'm going to switch that up to whoops, type the right number, I-30 and this is coding HTN, CKD with heart failure. It's all combo coded. And even though the doctor didn't link them, I can, per the WITH guidelines, per that convention that's in our ICD-10 guidelines. All right, moving on. I have diabetes complicated by CKD. So here our physician has done the link. So I don't have to think about it. I just have to code it. Now I'm on page 3 now. So I'm going to put in page 3. And I'm going to put in E1122. It's our code. Don't need to flag it. And it is AP3. Now with these combo codes, your guidelines can get very specific about meat. Our guidelines didn't go into that. So based that it's already linked and it's in the assessment and they're chronic conditions, I'm going to code it. I'm not going to worry about meat because I don't really have meat for the CKD. Well, actually I do. I take that back. I have stable. Now, when I code this, I'm probably going to put a note in here for my auditor. Okay, I can take out that question mark on meat, and I'm going to put in here a note that says that CKD is not staged. Okay, so I can't, that tells the auditor don't look for like an N18-4 because it's not there. It's not in the documentation. I can't make it up. It's just not there, so I can't code that. Okay, plan. Sometimes there will be a condition in here that I can code. It's not mentioned anywhere else. So, it may, be pertinent to something else and they pop it in there. So I do need to look at this and I don't see anything here that I can code. So I'm going to go up to the top of the chart. That's kind of my way of doing this because that way I don't miss anything. Now here I've got a chief complaint. Chief complaint, what do I need? I need meat. So I'm going to take note of what's here, but I'm not going to code from here yet because I don't want to have to find meat if I don't need to. Okay, so hypertension we've already got, congestive heart failure we've got, Diabetes we've already got. Chronic kidney disease. Here's something new. Hypothyroidism and GERD. So I could code from here. I'm going to kind of hold that for now. Hope maybe I'll find it in the problem in the past medical history where I won't need meat. Okay, moving on. HPI, patient doing well. She is a type 2 diabetic. If I needed it, there's provider's active voice. Perfect meet. Compliant with her medication, home blood testing, tries to adhere to her diet. It is well controlled, although it is complicated by CKD. So if that hadn't been linked in the assessment, here it is. Here we've got a stage. CKD stage 2 to 3. What do I do with that? You know what I do? I go with the lower stage unless there's something definitive somewhere else in the note that tells me it's really stage 3. So this lower stage, CKD stage 2 does not map. So I'm going to change my note up here. And I'm going to do CKD 2. So I can't, and the auditor's going to know I can't code that. Okay. Now, problem list we'll go back to. Let's look at the past medical history. Okay, we've got HTN already. Let me just mark in green. Got HTN. We've got congestive heart. We've got diabetes. We've got CKD. Here's the hypothyroidism. I'm going to code it from here. So what page is this? This is page 1. And we're looking at hypothyroidism EO39. Don't need a flag, but I'm saying PMH, page 1. Don't need to make any other notations on that. And so I've got that now coded, done. GERD, that was up there, and here it is in the PMH. So yay, I don't have to worry about meat for it. K219, oops, fat fingers there. 219, PMH 1. Okay, that one's covered. Anxiety. I know from my experience that anxiety does not map, so I'm not going to spend time on it. If I'm a new coder or I'm not sure, I'm going to go code it. I'm going to go look it up. And there are some, like if there are certain other ways of stating anxiety that are certain types of anxiety conditions that do map. So if I'm not sure, I go look it up. I don't guess. Okay, you never guess with this. You go look it up if you need to. Heart attack in 2018. This is a status code. It's an old heart attack. Okay, so I can capture that. So it's on page 1. It's I252. It's in the PMH. And it's on page 1 again. I'm going to say that again. That's kind of redundant, but I like to do it that way. Okay, AFib. AFib is an acute condition in this project. And so what does that mean? That means no matter where I find it in the chart, I need to find meat for it. So I'm going to, I don't want to forget about it. So you know what I'm going to do? I'm going to put it here. When it's not specified, it's I48991. It helps with the right keys. And over here, I'm going to question mark meat, because I need meat for that. And I'm going to mark also that I found it in PMH on page 1. Alrighty. So, and I'm also going to notate so I don't forget it. Meat. Okay. Surgical history here, I don't have anything, but sometimes we find things in surgical history. We might find documentation of an amputation. We might find some kind of organ transplant. We might find some kind of an ostomy surgery. We might find something like a thyroidectomy or a parathyroidectomy. They will impact the code because there are codes for post-procedural hypothyroidism and parahypothyroidism. So I've got to check that surgical history. I'm looking for octomy and ectomies, ostomies and ectomies, basically, or amputations. Are really important. Family history doesn't help me. Social history, sometimes it does. You know, if the patient has some kind of problem with alcohol or drugs and, you know, is addicted, I may need to pick that up. Allergies, not an issue for us. Med list. There is one med that I can pick up, and you know what? I see it right there. It is insulin. And our patient's a diabetic, so I'm going to pick up long-term use of insulin here. Okay, so I got another code. What page am I on? I'm on page 2. That is Z794, and I'm just going to say med list. Okay, if it's confusing, I may indicate the name of the med, but we all know Humalog is insulin, and it says insulin over here, so no question about that. Okay, so as I look, okay, I've got Eliquis here. And Eliquis, remember I'm on the lookout for meat for the AFib. And Eliquis gets used for AFib. It's a blood thinner. And when you have AFib, sometimes because the blood isn't moving as quickly as it should through your heart, it can clot. And so Eliquis helps prevent clots, therefore helps prevent things like strokes, but it's not provider linked. So you know what? Can't use that as meat. Okay. And then lorazepam would probably work as meat for the anxiety if it were codable, but the particular expression of it there is not codable. Review of systems. Review of systems is typically coming from the patient. Notice denies and admits. And we look for words like this, though every now and then there's something in there that we can pick up. And if we can pick it up, we're always going to need meat. So general, denies. Cardiovascular, admits the shortness of breath, denies. Denies, admits GERD symptoms. Remember, we have GERD as a diagnosis, and here the patient is saying, yeah, I feel that GERD. Admits muscle aches. Okay, it's an elderly patient, so it could be achy. Admits anxiety, denies suicidal ideations, denies headaches. All righty. Now, we've got something else. We have a BMI that is over 40. Now remember back when we were talking about E6601, it was like BMI. I wanted that because BMI of 40 or better typically indicates morbid obesity, although it is up to the physician to determine that, not the coder. If I have this, but I don't have morbid obesity in my note, I cannot code morbid obesity, okay? But this does give me meat for that morbid obesity code. So that came in handy. Examination. Okay, here's another source of meat for morbid obesity. If the doctor says it in the exam, that's your meat. So the patient here is described as morbidly obese. That's the diagnosis there. So we can use that as meat also. And you would just say PE over here for it's in the physical exam. Let's see, is there anything else of interest? Remember, we're looking for meat for something for AFib. So I hope there's going to be something of interest here. Ah, we got it. If we look under cardiovascular, irregular rhythm. That is doctor speak in the exam for AFib. And so I have meat for AFib in my physical exam. Alrighty, moving right along. Abdomen, nothing there. Okay, I am probably finished. So, oh no, I forgot one thing. I believe I forgot the BMI status code. That's rather important too. I need to code that. Okay, so that is on page 2, and that is Z, I believe it's 6841, and that's another one that I do want to verify. So I go to Clickadex, I go to BMI, body mass index, adult, and it was 44, and these are in a range, so 40.0 to 44.9, yes, Z6841. That's what I need. Okay, so Z6841, and that is in vitals on page 2. Whoops. Okay, So we are probably finished here. Once I hit submit, it's done and I can't change it. So I really like to take another look-see. First thing I double check, I'm really good at getting dates or years wrong. So I just verify 8/23/19. Got it all correct. Okay, I have a correct provider type. Provider ID is correct. Page numbers, I can tell they're all in the same range for the chart. I look at my codes. Now, typically, most of the time, you're going to have a code description as well. It's going to pop up. I couldn't set that up with this. So when you have that, that makes it easier to confirm. But let's just take a walk through. Okay, so from the assessment, I comboed all these, hypertension, and CKD and the heart failure, and that's I30O. There's the morbid obesity, the heart failure. Here's the DM complicated E1122. Moving on up, past medical history. There's my hypothyroidism. I've got my GERD. I've got my old heart attack. Okay, AFib, I found meat for, so that's a go. Okay, and then I've got my long-term use of insulin, and my BMI status. I'm done. Okay, that finishes our coding of this chart. In real life, I would have more of these and I would just move on to the next one. Okay, so and now Mrs. Tracy is going to talk to us about what happens after codes are submitted. Mrs. Tracy?
Okay, thank you so much, Miss Shirley. Wow, that was a great walkthrough on that with that charting on the last scenario. All right, so what happens after codes are submitted to Medicare? Well, Medicare uses data from risk adjustment codes to calculate a risk score for each patient. The cumulative risk score for enrollees in each Medicare Advantage plan are then used to determine future funding allocations for the insurance plans. And funding is based on the severity of illness of the members as well as some additional factors.
Thank you, Mrs. Tracy. Now, there are several absolute essentials if you are working as a risk adjustment coder. First and foremost, you have got to know your guidelines. You've got to know your ICD-10-CM guidelines and your project guidelines. They got to be in your back pocket because you don't want to have to keep spending time looking them up and you don't want to make mistakes because you forget about them. So you got to know those. You need to read every section in your chart. Um, you don't have to, worry about every semicolon, but you certainly do have to review that entire chart because a diagnosis that you could code can be anywhere in that chart. And when you come across a condition that you don't know anything about and you need to find meat for it, you've got to do some research. So you need some good research tools and you need to be able to ask questions. That's not a sign of weakness. Nobody knows everything in this business. And so we all ask questions and we get help from one another and we help each other out. So know your guidelines, read, research, and ask questions. And if you'd like to learn more about this field and this kind of coding, this is an excellent book, Risk Adjustment Documentation and Coding by Sherry Pro Bernard. It's a go-to book for those of us that work in risk adjustment. I believe there is a new updated version of it coming out sometime in March, I think. At least that's what I heard a month or so ago. So the timing may be a little different in the end. I don't know, but this is an excellent, excellent resource and very readable. So if you'd like to learn more about it, this is what I would recommend. And with that, just want to say thank you so much for coming to this webinar today. Thank you for your participation.
All right, everyone, how are you doing? I hope you all enjoyed the wonderful presentation put on by Miss Shirley. We want to thank you all for attending. Now, some of you may have had some questions throughout. We do have a large number of attendees here. So if we were not able to get to your question, we do have a survey. We encourage you all to fill out that survey at the end. Let us know what you thought of today's presentation. And if you have a question, you can feel free to ask us there. And we just want to let you know we've already shared the assessment link with you all here in the chat. Apologize, we did go over a little on time, but we did share that, at time. So if you all are still here, we appreciate you staying till the very end with us. Just a reminder, you must take this assessment upon the completion of this event, and you will have 48 hours to complete the assessment. After that, the assessment link will be closed. You can grab the link from here, but if for some reason you're unable to grab it from here, you will also be sent a responder email 1 to 24 hours after this presentation with the link and the password to access that assessment. And just a reminder, please do not share this link with anyone, as it is a violation of AMCI and AAPC copyright clause. And also a reminder, please provide your full name and correct information on your assessment. That will be printed on your certificate. So you want to make sure that it matches up to the name you have on file with AAPC or AHEMA. That way you get those credits to your appropriate account. And we want to thank you again for attending. Don't forget that we do have next week we have 2 more weeks of March Madness, but next week is our PCS coding event. It's a 3-day event, 12 CEUs. Yes, 12 free CEUs, but you must attend all 3 days to get those CEUs, okay? You can sign up on our website, amcicoding.com. Just go to the calendar and sign up if you haven't already for our 3-day PCS event next week. And I believe that is it. I want to thank you all for joining. Enjoy the rest of your day, and please don't forget to fill out the survey upon leaving today. Have a wonderful weekend, everyone. Thank you, Miss Rochelle. And thank
Thank
you so
you.
much, Miss Shirley.
Thank you, Miss Shirley, for a wonderful presentation. Coders, we'll see you next time. Enjoy the rest of your day. Thank you, Miss Tracy.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI.